Good morning. We're going to go ahead and get started. I'm Harper Price. I'm the Division Chief of Dermatology here at PCH, and it's my pleasure this morning to introduce you to my wonderful colleague and friend, Dr. Vanessa Guildenstern. Vanessa hails from the great state of Texas. After receiving her medical degree at UT Southwestern, she traveled to Phoenix to complete her pediatrics residency here, and then joined us in a fellowship in pediatric dermatology with Dr. Hansen and myself. And I was so lucky to have her join us in 2011 as faculty right out of fellowship, where she's remained ever since. Vanessa is a major contributor to resident and student education here at PCH and serves as the pediatric dermatology rotation course director for the pediatric residents as well as for rotating medical students. When she isn't at work, her and her husband enjoy running after their two very busy toddlers at home. Vanessa will be talking about a topic that is, I know, near and dear to her heart in our group at PCH here, Phaces, more than meets the eye. And so without further ado, Vanessa.
Thank you. So good morning. Oh, thank you. Good morning, everyone. Thank you for joining me today. So, I just want to say that over the next hour, I'm going to do my very best Dr. Price impersonation because she's a really good speaker. And I spend most of my time in clinic. I'm not on the speaker circuit. And so spending my time in clinic, I just kind of attend to patients. And then I've been trying to hide from Michael Olson, who's in charge of getting speakers for this series. But I was very kindly volunteered by Dr. Price, so here I am. So I'm going to start off with just a little pop culture pop quiz. Does anyone know where, this is a clip from a movie. Does anyone recognize the movie? Yay, thank you. I was afraid that people would be like too young to know this. But yeah, so this is a clip from Ferris Bueller's Day Off where Ferris's best friend Cam is actually staring at this painting. It's a famous painting called A Sunday Afternoon on the Island of Le Grand Jatte by Georges Seurat. And as he stands there, he becomes transfixed and mesmerized the longer he looks at how much detail is inherent in this painting. This is a technique called pointillism, whereby small, distinct, clear dots of color are arranged to form larger patterns. So my goal is that I'll sort of invoke a little bit of Seurat today too and help you appreciate the detail in Phaces syndrome. So the objectives today are fairly simple: define what Phaces is, figure out who's at risk, and then know what to do for those at risk. I don't have any conflicts of interest. I will briefly mention an off-label usage of medications. And then also, Phaces syndrome is a relatively new kid on the block. So as much as we like to practice evidence-based medicine, sometimes for some conditions there isn't a lot of evidence. So there aren't any large randomized double-blind controlled trials with this. So what we know is largely limited to expert opinion, case reports, and observational and descriptive studies. So I'll give you a hint and tell you that the H in Phaces stands for hemangiomas. So I figured we'd start there. Infantile hemangiomas are the most common benign tumors of infancy, affecting about 4 to 10% of infants. They represent the unrepressed proliferation of capillary endothelial cells. And they come in a variety of different flavors. So superficial is what you would think of. People often call those strawberry birthmarks. The deep type is more subcutaneous, often with an overlying light blue hue and telangiectasias. And the mixed type is a combination of both. There are several known risk factors for infantile hemangiomas, and if you commit to this picture to memory, you will know them all. So here's a mom with her babies in the NICU. So the risk factors are prematurity, multiple gestation, female, and I apologize, the ratio there 3 to 1, it's actually much higher. It's more like 6 to 9 to 1. Low birth weight and advanced maternal age. So here you notice that the little gal with the hemangioma is lower birth weight as part of a multiple gestation, is premature, and was born to a mother with advanced maternal age. So she has all the risk factors. Just kidding. Yeah.
Just exit out. Sorry about that.
Okay, so let's say that you're in the newborn nursery or in clinic and you meet this little guy, a couple weeks old, and has this fairly well demarcated pinkish purple patch and a beard distribution. Later that day you meet this girl, similar, just a different distribution on her face. So now you're wondering, are these port wine stains? Are these going to turn into hemangiomas? Hard to say. So we meet that proverbial fork in the road. You don't want to make a mountain out of a molehill, but you also don't want to miss the tip of the iceberg. So what to do? Thankfully, there are clues that will help you distinguish between each. So a port wine stain is present in its full form at birth. It's classically dark red purple, and it remains flat, at least through infancy and the most of childhood. A hemangioma precursor lesion, on the other hand, can present also as an area of erythema, but possibly pallor or just telangiectasia. And the key here is that this lesion evolves. It becomes whiter, thicker, it can ulcerate, it can bleed. So it would be unfair to ask any of you to distinguish between a hemangioma and a port wine stain based on one point in time. So when I meet a patient like this, what do? I see them back fairly regularly, so I can document whether it evolves or not. The patient on the right is my own patient, and I saw her fairly frequently during the first part of her infancy. And I picked a few pictures from some of her visits with me. And you see that over the first few months of life, her lesion stays pretty much the same. It's not grown thicker, it's not involved more areas of her face, it stayed about the same color. This is a patient of Dr. Price's, and I don't have follow-up photos of him, but know that this actually did begin to proliferate and declare itself as a hemangioma. Here is a patient that we all share in our department. He's a 27-day-old extern male whose mother reported having noted pink spots on his forehead and left upper eyelid at 1 week of age. And they subsequently spread rather quickly to the chin and neck area. And then what prompted her being referred urgently to dermatology was this wound on the lower lip. So here we know that this lesion is evolving. There are palpable areas, and it's complicated by ulceration. So nobody should mistake this for a port wine stain. So Phaces, what is it? It's an acronym. It stands for posterior fossa brain malformations, hemangiomas, arterial anomalies, cardiac abnormalities, and coarctation of the aorta, eye anomalies, sternal clefting, and supraumbilical raphe. You don't, no. So this is a relatively new kid on the block. In 1978, a neuroradiologist published a case series of 7 patients who he noted had cutaneous hemangiomas and also vascular and non-vascular brain anomalies. So it was just a case series. It wasn't really pursued until 20 years later. Ilona Frieden, who's very prominent in the pediatric dermatology world, coined the term face syndrome. And then 2 years later, Bolingas added the S for Phaces syndrome. And just to sort of put it in perspective, these movie posters are for the pictures that won Best Picture Oscars that year. So it's kind of incredible. Titanic's already 20 years old, but it doesn't seem like it's been that long ago that that was a popular movie. So this is still a relatively new area. So infantile hemangiomas affect about 4 to 10% of children, but only about 3.5% of those will have Phaces syndrome. So we're really looking for a needle in the haystack. When you separate infants specifically with large segmental facial hemangiomas, about 20 to 30% of them will have Phaces syndrome. Much like with infantile hemangiomas and Phaces syndrome, there's a very strong predilection for females. The pathophysiology hasn't completely been worked out, but it's thought to result from an early insult to neural crest and possibly mesodermal cells before they migrate. Some of the congenital arterial anomalies that we see in face predict this early insult. Pre-segmental primitive vessels typically regress normally by 36 days of age. And so we know from some of these persistent embryonic arteries that the insult must occur during that first month of life or so. There may be a possible role for some morphoregulatory genes, specifically the FEPH gene and the HOX gene. And then there's a lot of attention paid to the possible role for fetal hypoxic stress in the pathophysiology of this condition. So we know that in cases of Face syndrome, those infants have higher circulating levels of vascular endothelial growth factor and basic fibroblast growth factor. And in 2007, there was a study of women, of the placentas of women who gave birth to very low birth weight infants, both with hemangiomas and without. And in the hemangioma group, all of the placentas demonstrated some degree of disturbance of uteroplacental circulation. The genetics of this also hasn't been totally worked out. Because there's such a strong female predilection, the natural curiosity would be whether this could be an X-linked dominant condition. But what we find is that males are no more or less severely affected than females. There was a single case report in 2007 of a mom and her affected proband. And the mother showed skewed X-linked inactivation while the proband showed random X-linked inactivation. So that prompted a lot of interest in this subject. And so a couple of years later, there was a series of about 24 patient maternal pairs. Oh, okay. And so what they found is that in those with Face syndrome, the degree or the frequency of maternal skewed X-linked inactivation was no more or less frequent than in the general population. So ultimately, there's no real strong evidence showing that it could be X-linked.
What is the result?
Yeah, we're not really sure. Yeah, that's the thing. So there's a hypothesis that it could be some kind of fetal hypoxic stress, but that hasn't been totally proven yet. There have been 2 patients with Face syndrome with deletions on the SLC35B4 gene. This is a bifunctional nucleotide sugar transporter, but there's only been 2 patients. So no one's saying that this is a causative mutation, but we wonder whether this could maybe show some kind of susceptibility to the syndrome. And then in this very small subset of patients with both Face syndrome and moyamoya vasculopathy, there have been reports of variants in the RNF213 gene. So the significance of that hasn't been worked out yet either. So for now, we think of this syndrome as just being sporadic. So in 2009 and 2016, a lot of smart people across different subspecialties in pediatrics convened to decide on diagnostic criteria for this syndrome. So you have this same chart in your handout, so I don't expect you to memorize this up here, but just note that this is the 2016 revised diagnostic criteria, and you'll find it on the left-hand side. It's divided into the various extracutaneous systems that can be involved: arterial, structural brain, cardiovascular, ocular, and ventral midline, along with the correspondent major and minor criteria. And then on the bottom, you'll see that there are specific combinations of cutaneous features and then numbers of major and minor criteria that would then stratify the child into having definite or possible Phaces syndrome. So just like you were asking, sir, it doesn't have to be every single system that's involved. So segmental hemangiomas have predictable patterns. And so these are the 4 patterns. The S1 or frontotemporal segment is most predictive of cerebrovascular and ocular anomalies, while the mandibular segment is most predictive of ventral developmental and cardiovascular anomalies. The larger the hemangioma and the more segments that are involved, the higher the likelihood that the patient may have Phaces syndrome. So in 2009, we were taught to pretty much just worry about facial hemangiomas that are greater than 5 centimeters in diameter. But in 2016, our sphere of anxiety really increased. So now it's any large infantile hemangioma of the head. So not only the face, but also the scalp. And then there's this phenomenon known as face without face, where you could have a large segmental hemangioma of the neck, the upper trunk, or the upper trunk and a proximal upper extremity. And then, worst of all, you could actually have face without a hemangioma. Oh, sorry. So who's at risk for Phaces? After that, it makes me feel like everyone, but So basically, anyone with segmental hemangioma in these characteristic locations, or anyone with any of the other major anomalies found in the other organ systems, or a combination of both. So now we're back to our little 27-day-old that we met with this segmental hemangioma and this ulceration at the bottom of his lip. You notice on the side view that he actually also has some involvement of that S2 segment as well. Here is a different patient with no facial involvement whatsoever, but a 6 centimeter wide hemangioma of the neck. So this would also be a patient where you would be concerned about possible Phaces syndrome. Here's a little gal with a combination type hemangioma, primarily affecting the S2 and S3 segments of the right side of her face. And here we have a little 5-week-old, also with a very extensive segmental hemangioma, affecting pretty much all of the segments. So now we go into that point where I'm trying to help you to see what's beyond the eye, and not just focus on the hemangiomas, but all of these other various anomalies that can be seen. Cerebrovascular anomalies are by far the most common extracutaneous manifestations seen in about 77% of Phaces patients. They're typically arterial, very rare reports of venous and cerebral sinus malformations. These are all the various different arterial anomalies that can be seen. And of note, I'll call your attention to the third one in the list, stenosis or occlusion that can be progressive. So these would be lesions that may not be present on initial imaging, but then become progressively more stenotic or occluded over time. And that's important because that could increase their stroke risk. So here is a patient of mine with Phaces syndrome. And I credit Dr. John Curran, my friendly neighborhood neuroradiologist, for help with creating this slide and the next one. So he's highlighted for me the left internal carotid artery there, nice and intact. But you find that on the right side, it's missing. So this patient has no right internal carotid artery. And then this slide, I understand, is quite busy, but you don't have to be a neuroradiologist or even a doctor to know that this is a very asymmetric picture. It doesn't look normal. So the yellow arrows point to a dilated, large left internal carotid artery. The blue arrow points to the right middle cerebral artery that's being fed by the posterior circulation, which is the red arrow. That's abnormal. And then the green arrow points to the A1 segment of the left anterior cerebral artery, giving rise or feeding to both of the distal anterior cerebral arteries, and that too is anomalous. Structural brain malformations affect up to half of Phaces patients. It's typically in the posterior fossa. And so again, this is the same patient with all those vascular anomalies. He has a dysplastic and hypoplastic left cerebellum, and there's an incidental note of this rather large arachnoid cyst as well. Cardiovascular anomalies can be seen in 41 to 67% of Phaces patients, with coarctation being seen in up to a third of them. So this is a picture of a fairly typical coarctation, where the coarct is along the distal part of the arch, the descending part. However, in Phaces syndrome, there's a very characteristic anatomy. The coarctation tends to be along the transverse part of the arch. There tends to be associated aneurysmal dilation, highlighted by the yellow the yellow arrows. And oftentimes there's aberrant origin of the subclavian arteries. So in this picture, those white arrows are pointing to both subclavians arising distal to the obstruction. So why is this important in clinical practice? Can you rely on measuring upper extremity and lower extremity blood pressures? Can you rely on listening for a murmur? And the answer is no. So in the case that both subclavian arteries arise distal to the obstruction, there will be no difference in the upper extremity versus lower extremity blood pressures because all the major arteries will have arisen past the point of obstruction. And very rarely is aortic coarctation in Phaces syndrome associated with aortic or mitral valve insufficiency. So you won't really hear the murmur either. Ocular abnormalities affect about 16% of patients with Phaces. They're divided into anterior and posterior segments, with the posterior segment anomalies being major criteria. Not listed on here is glaucoma. It has been reported in these patients, but it's not part of the diagnostic criteria yet. This is one of my own patients. She has a pretty obvious microphthalmia of the right eye. You're probably wondering, where is her hemangioma? I promise I'll show you a picture of it, but it's actually on the left side of her face along the preauricular area. So hers is a fairly unique case in that her microphthalmia is actually contralateral to her hemangioma. Ventral midline defects are seen in up to 21% of Phaces patients, and they can present a variety of ways: pits, clefts, papules, supraumbilical raphe, and then a very small percentage of Phaces patients may even have endocrine abnormalities, hypothyroidism or hypopituitarism. So now we're back to our little guy that we've been looking at through the talk. What I didn't mention at first is that the very first abnormality that Mom noted on his skin was this white little papule on his sternum, and she related that it would sometimes become raised and then get flat again. So we actually had a sternal cleft, a midline defect even at birth. This little girl has a fairly large surgical scar from recent repair of a large supraumbilical raphe in association with her hemangioma. So the diagnostic criteria in 2009 is kind of reviewed here. And importantly, in the 2009 criteria, there was a special note that greater than one anomaly in a certain organ system only counted for one criterion. But in 2016, there's no such disclaimer made. And this basically expands the definition of definite face to possibly include hemangiomas of the neck, upper trunk, or trunk and proximal upper extremity. So what do you do for a patient like this? Pretty much start off with the simple things, right? Examine the patient. So look at the hemangioma, determine whether it's segmental, what size it is. Look for any potentially obvious ocular abnormalities, like my patient with microphthalmia, and look for any midline fusion defects. Certainly refer to pediatric dermatology if you find that you are encountering a hemangioma where you feel like Phaces might be an issue. And consider pediatric surgery referral in the case of supraumbilical raphe. An echocardiogram is part of every workup for Phaces syndrome and may prompt a pediatric cardiology referral. Sometimes cardiac MRI, MRA is also pursued, particularly in helping to kind of guide the surgical approach to repair of a coarctation. And then in cases of non-obstructive aortic arch anomaly, it's important that these kids continue to follow with cardiology with follow-up echocardiograms in case those obstructions become progressively more pronounced. MRI, MRA of the head and neck, importantly and neck, must be obtained, preferably with gadolinium, preferably by the time a patient is 3 months old. And then, interestingly, up to 50% of Phaces patients may also have an associated upper airway infantile hemangioma. And depending on when you meet the patient, they may not have symptoms yet, so that would be a good way to screen for involvement there. That may prompt referrals to neurology, neurosurgery, or endocrinology, particularly in the case of an empty cella turcica that might indicate a risk for hypopituitarism. And then I've highlighted in bold here this developmental pediatrics referral. This is something that's gotten a lot more attention in the pediatric derm community over the past 5 years or so. And that has to do with the fact that a lot of these patients end up having developmental delays. So in 2013, there was a study of 29 Phace syndrome patients less than a year old, and 20 of the 29 demonstrated some degree of developmental delay. So definitely consider this in your patients. An ophthalmology exam, obviously to look for all of those anterior segment or posterior segment anomalies. And then thyroid function testing that might prompt a pediatric endocrine referral if found to be abnormal. There are some unfortunate potential long-term comorbidities of Phace syndrome, particularly stroke, by mechanisms of either thromboembolism or perfusion deficits. 60% of these are diagnosed in the acute period with a median age of 10 and a half months. And the most common presenting signs and symptoms are seizures and or hemiparesis. So there isn't a whole lot of information published on stroke in Phaces syndrome, but there is a literature review of the 22 published cases that was published in 2012. And they basically looked at all of the cerebrovascular anomalies that these patients shared. And it was found that the vast majority had narrowing or non-visualization of one principal vessel or more. They also looked at the distribution of these hemangiomas in those patients and found that most of them had S1 and S3 segment involvement. And if you remember that those are the segments that are most predictive of cerebrovascular and cardiovascular anomalies, it makes sense. So, and the MRA of the head and neck can help to stratify these patients into low, intermediate, and high risk for stroke. I didn't list exactly how that stratification is made because there's a very long list of those different anomalies. But just know that based on how they're stratified, it kind of helps to guide what kind of follow-up care they need. And it would also prompt us to counsel them not to play in any sports or activities that might involve extreme neck positions, like wrestling. Some other potential long-term comorbidities include headache, with earlier age at onset and more severe headaches. So in a patient with Phase syndrome, if they have a new onset severe headache, changing headache quality or frequency, and certainly in the case of any neurologic symptoms or signs, that should prompt repeat imaging for those kids. Localization-related epilepsy and infantile spasms have been reported. Vision impairment can result from both amblyopia and astigmatism. Respiratory compromise can occur, especially in the case of an airway hemangioma. And hearing loss can also occur by the mechanism of either sensor and neural hearing loss or through compression of the eustachian tube by the hemangioma itself. So I showed you this picture earlier. So this would be one patient where even if her newborn hearing screen were normal, she should have repeat hearing testing done to exclude any compromise of that by her hemangioma. There's a lot of sort of oral motor problems that can happen with these kids, like dysphagia, feeding disorders, speech disorders, language delay. My patient with all of those cerebrovascular anomalies and the hypoplastic cerebellum has definite speech delay. So the risk of that goes up with posterior fossa malformations, airway hemangiomas, hearing loss, or having had a prolonged cardiac surgery. So all of these kids should have a speech language eval by the time they're 2. And lastly, enamel hypoplasia has been reported in the case of intraoral hemangiomas. So hypothyroidism can result as well, either from an ectopic thyroid or thyroid dysgenesis. It can have later onset, so definitely screen in the case of development of symptoms in later childhood. And growth hormone deficiency is possible. So I alluded to this earlier, but if there's an empty cella tristica on the MRI, or if there's a history of neonatal hypoglycemia, that should prompt consideration of growth hormone deficiency. And hypogonadotropic hypogonadism and late onset adrenal insufficiency have also been reported. So something that often goes kind of unmentioned in the literature is this potential impact on psychosocial quality of life. So in 2015, there's actually a validation of a quality of life scale for use in infants or patients less than 18 months of age. And what they found is that there's a significantly larger effect on quality of life with increasing hemangioma size and with facial location. And not only for the child, but also for the parent. They have a lot of feelings of fear, panic, guilt, and unfortunately can sometimes even be accused of child abuse. So an important point to make here is that this is irrespective of whether the patient has Phaces or not. Even a patient with a facial hemangioma is subject to the psychological distress that can create as a child gets older. So we're very sensitive to that in dermatology and typically treat all patients with facial hemangiomas. So medical therapy has evolved quite a lot, much like our taste in milk. So kind of like how dairy milk is out, vincristine and interferon alpha are not really used anymore. Prednisone, like soy milk, is sometimes used in special cases. And then propranolol is like the almond milk of now. So that's our first-line treatment for hemangiomas. So this all kind of came to light with this landmark paper published in the New England Journal in 2008, detailing the experience of some physicians in Paris caring for 2 patients who had developed cardiac complications while being treated for their hemangiomas with prednisone and were subsequently placed on propranolol. So this patient had developed high output cardiac failure after having been on prednisone for this eye-occluding hemangioma. So he was started on propranolol, and lo and behold, they found that the longer he was on the propranolol, the more and more his hemangioma involuted. So since then, there's been dozens and dozens of studies looking into the efficacy and the safety of this medication. And there's now an FDA-approved formulary type called hemangioma that is specifically FDA-approved for infantile hemangioma. The mechanism of action of propranolol isn't exactly known for how it may help to involute these hemangiomas. The hypotheses are that it may have something to do with vasoconstriction, inhibition of angiogenesis, or possibly induction of apoptosis, but this hasn't been proven yet. Propranolol is not without its possible side effects. Some of the common ones we see are sleep disturbance, reflux, sometimes cool, clammy hands and feet. But thankfully, the more serious ones are very rare: bradycardia, hypotension, hypoglycemia, bronchospasm. So because of this, we don't treat just any patient with a hemangioma with propranolol. We try to be good stewards of its use. So in general, those that we treat with propranolol are those with a facial hemangioma that may cause disfigurement in the future, those certainly with periocular involvement, airway involvement, any difficulty feeding, and certainly anything that's ulcerated, painful, or infected. So here's the little gal whose picture you saw when she was 5 weeks old. Unfortunately, a couple of weeks later, she developed this ulceration on her upper lip. So she obviously, for multiple reasons, was a good candidate for therapy. And this gal with that large supraumbilical raphe scar has unfortunately developed an ulcer with superinfection there on her chin. So another good candidate for treatment. So this is our little guy that we've seen a lot of, and this is him at about 1 month, 3 months of age, and 6 months of age while on propranolol therapy, and you can see how his stain has become markedly lighter over time. He didn't look very happy in that 3-month mark, though. Here we see our little gal at 5 weeks of age, 3 months of age, and 5 months of age. So you see that bulk over her right upper eyelid has definitely decreased, and her hemangioma continues to lighten. And here she is at 2 years of age. She still has some vascular discoloration, but that is expected to continue to improve over time. Here's my little gal with the microphthalmia on her right side. I promised you I would show you her hemangioma. So there it is on that left preauricular area, and here she is, about 3 years later, looking great. I know her hair is in the way, but there is no hemangioma underneath there. So a special case is propranolol use in patients at risk for stroke. For these patients, we're definitely more cautious with lower target doses, slower escalating doses, dividing doses TID versus BID, and definitely doing all of this in conjunction with our friends in neurology and cardiology. SPECT scanning can be an adjunctive tool as well, particularly to assess for any deficits in perfusion once they're on therapy. These are all of my references for your viewing pleasure, and those are all listed on the back of your handout too, in case you want to do some more reading on that. And before I take any questions, I'm just going to make a plug. May is Melanoma Awareness Month, and these are the adorable children of my friend and colleague Dr. Rusi in dermatology, and they're all showing you what you should be doing as Memorial Day weekend is upon us. So wear a hat, wear sunglasses, wear sunblock. Protect yourself, don't get a sunburn. Okay. Any questions from anybody? Yes, awesome.
Great talk, by the way. I love culture references. So if there are cases of things that are not associated with
Mm-hmm.
are there other key findings associated with things that would really trigger a send a signal up that you should look for
think the biggest one, because cerebrovascular anomalies are so common in Phaces syndrome patients, like 77% of them, I think if you saw a combination of cerebrovascular and structural brain anomalies, that should be a red flag for sure. And then the other thing would be that really specific anatomy of that coarctation, kind of being over the transverse arch with the dilation and the aberrant subclavian artery origin. Those would be things to kind of hone in on. Yes, Micah.
I was unaware of the different stages of
Perfect.
the syndrome period, so I learned a lot. You're saying that the propranolol use that was basically serendipitous.
Yes. Mm-hmm.
What was the original condition that first patient?
So he developed high output cardiac failure while on prednisone for this hemangioma. Mm-hmm. Yeah. Dr. Sood.
So first, I have a question mark for Rachel. So I can get one of the slides that has the large.
Oh, yes. Uh-huh. Mm-hmm.
So obviously when you see it before you do any imaging,
Mm-hmm.
I guess what else would you look for to be like, oh, I should do the workup for the patient? So
Mhm.
in my mind, I'd be like, do one or two times where bust that stethoscope and see if it has an
Which may not be helpful, right?
I guess with those gray zone ones, you know, I know it's hard, but like at what time, if you get one slide where you get a really big deep one, that's,
Mm-hmm.
so like, when would you like, commit to that maybe workup?
So that's a good point that you bring up. In the 2016 Diagnostic Criteria, there was a little blurb in that article that actually that whole size cutoff of 5 centimeters isn't exactly evidence-based. Again, it's kind of like observational and based on expert opinion. But they did make a little side comment to say that in their minds, large meant any hemangioma that might be 20 centimeters squared or greater. So like 5 by 4, that's where that 5 comes from. So that would be one thing to consider, is if it were 20 centimeters squared or greater. And then specifically where it is on the trunk, so upper trunk, and possibly with extension to the neck and the proximal upper extremity. So that patient, the picture that had that large defect, that wasn't actually her hemangioma, that was a surgical scar from her supraumbilical raphe having been repaired. Yeah. Any other questions, comments, thoughts? No. Okay. Well, I'm here. I'll stay up here if somebody just wanted to ask a question, not in front of everybody. All right. Thank you all for coming.